welcome everyone. We're going to do some cases this week from now until the Viva, until the oral exam. So welcome. We'll start with case 1. Do we have a volunteer for this one? They do start easier and then get a little bit more difficult, I think, as we go along. So, and can I just say as well, like if you don't want this to go on YouTube, just please send me an email and we can cut it out. All right. So if you get things wrong, there'll be so many instances of me on YouTube getting stuff totally wrong. So please don't feel, like it's all, I hope, like a safe learning environment. And yeah, this is Echo. We're all still learning. So yeah, any volunteers for this one? It's good to just practice going through and just keeping it pretty simple.
Yeah, I mean, I'm always happy to volunteer because exams coming up, but I mean, other people should also I don't want to hold the session, so
I don't want to put anyone in the spotlight.
I'm happy to give it a crack, Emma. I need to step up. Yeah, why not?
Cool. All right, go for it. Do you want to read out the stem, Andrew?
So 78-year-old female, urosepsis and hypertension requiring vasopressors, cold left leg, which is thought to be a left femoral artery thrombus, and they're asking whether there's a cardiac source of embolus in the transthoracic. I'll just make my screen a bit bigger. Give me a second. So here we've got a parasternal long axis. So first looking at the left ventricle, walls aren't particularly well defined, but I would say it, generally speaking, looks a little bit hyperdynamic. And once again, they're moving well. The right ventricle is moving well. Looking closer at the valves, there might be something flicky on the aortic valve, but really I'm not sure. I have to have a closer look. So neither the aortic valve or the mitral valve is particularly well defined. And then the atria themselves, the left atrium looks normal to my eyes, just grossly. Looking on the parasternal short axis, I would say that, yes, the left ventricle seems to be hyperdynamic with quite almost like a kissing ventricle appearance.
Okay, Andrew, just because we're starting off, I am going to ask you a few questions, and maybe so in the Viva, they would probably interrupt you and do this at the time. So what wall are we looking at here? Can you see my pointer?
Yes.
Yeah.
So that's the septal wall.
Which part of the septum?
So you mean like anterior septal wall?
Yeah. So anteroseptum, nice, basal and mid, and this wall here.
So inferior lateral wall.
Yeah, very nice. You mentioned the RV at this level in the parasternal long. This is the RV outflow tract.
Yep.
If you're in a low plaques, it would be the RV wall, but just a little pedantic point for that.
Yeah, sure. Absolutely.
Yeah, we'll keep going. Obviously, where my pointer is here, what wall is this?
So that would still be. I'm not sure. So it's close to the septum, so it would be. I think it would be infraseptum. I'm not sure.
That's okay. So anteroseptum here, and then infraseptum here. Yep. Yeah, inferior wall. You've got your anterior wall, anterolateral wall, and infralateral wall. So just remind yourselves of the actual walls. We'll move on from that now. All right.
So looking, I assume it's the same. Okay, so now we've got a apical 4-chamber view. There are aspects of it that aren't particularly well defined, such as the right ventricle free wall and the apex. But looking at the LV, it's probably not as hyperdynamic as I had initially thought. Specifically, the apex looks down to me. So it looks like there's not as much movement there.
Would you expect to see apical movement in a non-foreshortened image of a 4-chamber?
You might not expect to see as much movement, but there doesn't seem to be a lot of movement at all to my eyes.
So you're worried about the apex?
I'm worried about the apex, yeah. But I think it's not particularly well defined, so I'd have to have a closer look at it. So looking at the on color Doppler at the mitral valve, there is an eccentric jet from the posterior leaflet. it would appear. Sort of heading towards the sort of the septal side, I guess. I'm not quite sure what to call that side. But there's certainly some, I wouldn't call it particularly, probably mild at this stage in this view.
Yeah. Anything else you want to say about the four-chamber, Andrew, on the left?
So once again, looking at the four-chamber. So looking in tracheal septum, doesn't look like it's bowing. There's no symmetrical bounce. I think the atria are a little bit big. Just eyeballing, I'm not sure though. Or maybe not. 1/3, maybe not.
How about the RV size and function?
So RV size and function, a little bit tricky because the free wall's not particularly well defined. I can see trabecular at the apex of the RV. So grossly, it might look a little bit down.
Yeah. And what's your main worry looking at that four-chamber? And what might you want to assess more looking at that? What part of the heart?
So I guess you could ask whether it's sort of like a left main disease might be causing this. So left main down. I'm not sure though.
Because of what are you mainly concerned about?
So the apex running round to the RV sort of, I guess if it's the RV, it could also be the right coronary artery. Perhaps that might be a better guess.
Okay. I think these are the money shots now, Andrew, coming around to them. Sorry I've taken so long to get you there.
No, need to go through things and learn. So, I mean, the apex looks abnormal. It almost looks like it's ballooned out or like an aneurysmal appearance to the apex.
Nice.
And I would really be suspicious to wonder if considering the history, whether there's a clot in there.
Lovely. So what do you want to do next for this patient, Andrew?
I'd like to fan through the apex and then consider contrast if that doesn't help.
Lovely. So you're going to do off-axis imaging, really fan through that apex, and then give contrast. Very nice. That's what we did, and there was a laminated thrombus in there, and no doubt it was that was the source of cardiac embolus. Well done. I know you're just starting off in your advanced echo learning and stuff, so I thought you did really well. It's good that you recognized here that apex just looks really funny, like it just, it doesn't look quite right. Maybe it's starting to look aneurysmal in this particular plane, I think. And there was no other striking abnormality apart from that, I would say. The left atrium is dilated. I put this in just to show that the sonographers were putting some colour on the LV, but they actually didn't fan up and reduce the scale and put colour up at the apex. Which I thought you might have, maybe said, like, I want to see some colour with reduced scale up at the apex. I want to see fanning through with that. So as you were being shown these images in a Viva, really focusing on giving a broad overview of what the heart looks like, but then focusing on the pathology and really going for where the money is early, saying that apex looks aneurysmal, it's akinetic. I'm concerned that's the source of, potential thrombus in this patient. I want to fan through off axis, pop some color on, reduce the scale. If I still can't see anything, we definitely need to be considering contrast in this patient because I'd still be highly suspicious. I think when you first start off with echo, there's a tendency to go down rabbit holes and maybe find pathology that's not there, which I think is what you did here with the, eccentric jet. I think you got yourself into a little bit of a difficulty with that. This is a trace of
trivial,
MR. Trivial. And I think in real life you would say that as well. It's just when you're shown it in a Viva, sometimes you're looking for things, that are not really there. So that's just showing a trace of MR. And then I think these show beautifully what the sonographers are doing, some really fanning down posteriorly into that apex, showing this aneurysmal LV wall. I didn't share any cardiac history of the patient because on admission we didn't actually know what her cardiac history was, and it wasn't until we saw these that in fact she had a prior LAD infarct, with this akinetic apex. Very nice, good job, Andrew. Guys, do we have any volunteers for this next one? Or it might just be me and Hyeon doing a session. Can I?
Hey, Emma, Zoe here. I can volunteer.
Perfect. Thank you, Zoe. Do you want to read the stem?
The 52-year-old man with NSTEMI, triple vessel disease, awaiting cabbage, cardiogenic shock on dobutamine and noradrenaline TT to assess biventricular function of valves.
This is his actual angio, and even I can tell that that's not normal. His triple vessel disease. All right, let's get onto it. I'm not going to interrupt you. All right, we might just go through the whole of the case, and then we can come back and go through it individually. So I might skip you through.
Sure. So starting off with the LV focus peristernal long axis window. The most abnormal thing I can see here is a dilated cardiomyopathy with a severe global systolic dysfunction. The anteroceptor wall and the infralateral wall here are the anteroceptor wall is probably akinetic and a hypokinetic infralateral wall with a dilated left atrium. The RV also looks dilated and appear to have severe systolic dysfunction. Seeing a color flow Doppler here over the mitral valve area showing a central mitral regurgitation, the etiology of which is likely functional due to severe dilatation of the LV and left atrium. Some short axis imaging here, one at basal level, one at mid level. Both are confirming a diagnosis of severe global LV systolic dysfunction. Difficult for me to pick up if one segment is more hypokinetic than the other, but looking again at the anteroceptor wall, it's akinetic. I think the contractility of the LV is mainly in this twisting kind of motion rather than translating to a radial fractional area change. Some 4-chamber imaging here showing dilated LV and RV and severe biventricular dysfunction with left and right atrial dilatation. The walls that we can see here is the infraseptal wall and the anterolateral wall. Both looks akinetic to me. There's some color flow Doppler over the mitral valve, again showing that central mitral regurg that we could see before. In terms of grading severity, I'm worried that the color flow Doppler alone could be underestimating severity due to elevated left atrial pressure and elevated LV EDP. There is a LV focus shot with a color box placed at the left ventricle apex with reduced color flow scale looking for a presence of a thrombus. I think there's likely some artifacts there in that 2D picture, and I cannot convincingly see I cannot convincingly see an echogenicity that would be representative of a thrombus.
What might you want to look for next, Zoe, if you were doing the scan or you were standing with the sonographer? What would you ask them to do next?
So I would like to complete the assessment of the LV looking at the 2-chamber and the 3-chamber combined with off-axis imaging and reduced depth with color flow interrogation. Look for the presence of apical thrombus, and then thereafter I'll ask for a definitive contrast scan. So short axis imaging at the mid and apical level. There is an echogenicity attached to the inferior apical segment, which may represent a thrombus in this case. I'll see a cross-section of that, see if I can visualize it in multiple different views to confirm whether if it's artifact versus a thrombus, and I'll look for a definitive study. Okay, so it looks as though with some off-axis imaging, there is a echogenicity that's attached to the inferoseptal apical segment. It's quite rounded, and it's got increased echogenicity, which is likely to reflect chronicity of this thrombus within the apex, and that is in keeping with what we're seeing here, which is dilated cardiomyopathy.
All right. Well done, Zoe. Great job. Let's just go through some of the things that I picked up on. So I thought you did very well with this. Like, you didn't have to be prompted for what the walls were. You just said, what they were and gave a grading, which I actually really, I really appreciated that. I thought you did well. I think I would have said the same, severely dilated, severely, severe systolic dysfunction, akinesis of the anteroseptal wall, hypokinesis of the infralateral. Dilated RVOT. I think you said you mentioned that severe RV dysfunction on this plaque. You can't make that call on a plaque because all we're seeing really is the RVOT if it's on axis. You could argue maybe this is a slightly low plaque and you are seeing a little bit of the RV, anterior wall, but yeah, calling RV function on this, I think all we can comment on really is the RVOT size and whether it's dilated or not. And whether the wall is thickening or not. But anyway, I think you picked up the MR, which looks mild to moderate, but you nicely said in the 4-chamber view that you might underestimate severity with color because it's all about pressure gradients, and that's showing you about velocity of blood cells, and so color might underestimate it in these circumstances. So you wouldn't hang your hat on color alone, which was nice. They probably would quiz you on the walls here and ask you to say which was akinetic, which was hypokinetic, which is would be a little bit harsh, I think, in this particular view, these windows, because you're not seeing clear endocardial border definition. So it would be a little bit tricky to call, but I think you could, these look sort of more hypokinetic, don't they? And the rest of it looks akinetic. You see this little structure here? Now that I'm pointing it out, that is the bit of thrombus that you're seeing there. Yeah. And this is probably pap muscle, but in a patient with a severely dysfunctional LV, you definitely want to look at this a little bit more as well, because it looks quite suspicious. So even up here, this all looks a little bit suspicious as well. Yeah, you've probably got a bit of near field clutter coming in here, but you'd be, you definitely wouldn't want to be calling this artifact. You'd want to be calling it pathology until proven otherwise. And nice, that's where you mentioned about severe biventricular dysfunction, global sort of dysfunction, biatrial enlargement, some functional MR, which again looks mild mod, but may be underestimated with the hemodynamics of the patient. Zoomed in on the LV, you can't see a thrombus here. I agree with you. Obviously, we often get this, which is a near field clutter, and it can make things really tricky. This is an off-axis. This is actually a foreshortened image. Now, if you didn't know what you were doing, and you can see how the apex is sort of moving, if you didn't know what you were doing, you might just stop there and say, oh, there's no LV thrombus, right? And even if you did orthogonal views through here and got a 2 and a 3-chamber, you still might miss a big apical thrombus, because the key thing I wanted to highlight in this case is you absolutely need off-axis imaging. You need to make sure you're not foreshortened, that you're definitely seeing the true apex of the LV. Otherwise you will, absolutely miss this, whopping LV thrombus. And then you can actually see it really nicely just coming in here. What would your differentials for this mass be?
A differential will be thrombus, certain malignancies and intracardiac tumors, artifact, and depending on the location, this could have been infective endocarditis or other infected thrombus.
Yeah, nice. Nice. I think those are the main things, like, thrombus, tumors, whether primary or secondary, like metastases or whatever, and infective, vegetation. I'd put artifact way, way down the list because you've got this sort of substrate for it being pathology, and you're seeing it in more than one view, and it doesn't really you can't really explain this with physics, can you? So I'd put artifact. And if I was going to say artifact in my differential, I'd preface it with that in this case. I'd say I think it's highly unlikely to be artifact because I can't explain it by physics. I can see it in more than one view, something like that. Nice. And then obviously, the off-axis imaging, so off-axis 2-chamber, sort of tilting down, seeing at the apex. And then you can actually see the sweep through that the sonographer did here. So tipping posteriorly, bringing in the coronary sinus, and then rotating round to a 2-chamber, really bringing out the LV thrombus. In this case, you actually don't even need a definitive contrast. Sure. Yeah. You could just call this, it's highly likely to be LV thrombus, obviously taking into consideration the rest of the clinical history. He actually did go on to have a contrast, and it confirmed it was in keeping with the thrombus. But very well done, Zoe. Good job. Next case. This is fairly straightforward and something quite typical that would come up in a Viva, I think. Do we have any volunteers for this one? Heywan, do you want to get a bit of practice in?
Yeah.
Yeah. Do you want to read the stem?
Yeah. So 35-year-old, 35-week pregnant. Come to ED with increasing shortness of breath and which is acutely worsening. She's tachycardic and hypoxic and hypocapnic, and blood pressure is it's normal. Some pulmonary venous congestion here, but otherwise probably cardiomegaly. But otherwise unremarkable X-ray. Okay. So this is deep parasternal long axis view. So here, hyperdynamic LV function consistent with pregnancy, dilated RVOT, but I like to look at other views. In the far field, there are multiple B lines concerning for interstitial pathology. Yeah. Okay, so very abnormal parasternal short axis, dilated right ventricle with septal flattening during systole and diastole, suggestive of pressure and volume overload. Yeah. So there is elevated PA systolic pressure based on the estimation by the TR jet. But it's TR velocity, but RV systolic pressure would be just under probably around 60 mark, depending on what the RAP is. I can see here that the longitudinal function is preserved, but FAC is significantly reduced. And putting all this together, I'm very concerned about pulmonary embolism. Yeah, again, normal TAPSI, but TAPSI can be normal in pulmonary embolism. So I'd like to look at, and I'd like to also look at S prime, but we already have looked at FAC. So I don't think I can be reassured by these findings.
What would you like to do next for this patient, Heywan?
So a few more images on echo that I like to look for is so RVOT VTI. I'm looking at shortened RVOT acceleration time, so less than 60 would be a typical finding. Apical 4-chamber view looking at McConnell sign. So presence of McConnell sign and sort of 60-60 sign would be very highly suggestive of pulmonary embolism, and patient requires CTPA to confirm the diagnosis. Nice.
So it's obviously an echo exam, so they wouldn't be asking you to interpret that, but massive bilateral PEs in this patient. I was going to ask you, what is the 60-60 sign you mentioned, Heywan?
Yeah, so it's indicative of acute increase in RV afterload. So specifically PA systolic less than 60 in the setting of RV acceleration time of less than 60 milliseconds. Yeah, and why is it less than 60? Like, why do they have? So you know what?
to be very pedantic, it's actually your TR, it's your RA to RV gradient of less than 60. So it's actually your TR maximum pressure gradient of less than 60, rather than the PASP. So when it was first described, it doesn't take into consideration the RAP. Yeah, so it is the tricuspid regurg pressure gradient. Why is that so? Why is that less than 60 and your accel time less than 60 sort of indicative of acute PE or acute pressure overload, as you say?
I mean, I think my understanding is...
Why not greater than 60? Pressure's greater than 60.
Yeah, I'm other than to say that RV is sort of unable to generate high I mean, it all sort of indicate acute stress. RV is unable to generate high pressures in the presence of sudden increase in afterload, but I'm not sure why the value is at 60.
No, I mean, that's perfect. Yeah, there was obviously studies that have looked at it being more sensitive and specific at those cutoffs. But yeah, it's absolutely because your RV just can't generate high pressures generally. So if you're seeing pressures above 60, that often points to there's likely an element of chronicity. Otherwise, the patient would probably not be alive. There are obvious exceptions to that, but generally speaking, I think this is a nice case to demonstrate. This is not perfect for a McConnell's. There's probably a little bit of a McConnell's going on, but just for everyone else listening, what is McConnell's sign?
So it's high perikinetic RV apex with hypokinesis or akinetic RV free wall.
Yeah, very nice. And it's due to that sort of apical traction that you get, isn't it? And that's again with acute pressure overload. Nice. Is if you see that, are you 100% sure that it's a PE? Loaded question.
No, it's just a sign of acute increase in RV afterloads. You can also see in things like ARDS.
Yeah. Any other pathologies that you might see in McConnell's?
Yeah, other than some whole range of acute lung pathologies, I'm not sure.
Yeah, I mean, so you see it in any, it's like pulmonary arterial hypertension, often the precapillary chronic pulmonary hypertensions, you can see it because as they progress through their RV remodeling and everything, they get that apical traction. So you can see it in severe chronics and RV MIs as well. So RCA infarcts, you can see McConnell's. So you wouldn't hang your hat on any one sign, and obviously gold standard diagnosis is a CTPA because of the non-specific nature of RV strain, but I think putting it all together, it was highly likely, wasn't it? And often, now patient groups, they're not stable enough, are they, to take for CTPA, so you just have to put it all together and make a call sometimes. She was obviously stable enough. The other thing I was going to mention, nice to pick up on the discordance between fractional area change and TAPSE. Often it's not uncommon that we see this RV being reported as dilated with normal function when it is, severely dilated with severely abnormal, severe systolic dysfunction with a preserved TAPSE. And again, that's because of that rocking that you get in acute pressure overload state. So really important to not only look at, the longitudinal markers, but really just eyeball the fractional area change, even if you can't measure it out as well, hey? So that you can see that the area of the ventricles it's hardly changing. But just that's really nice that you recognize that. Obviously, we give you the fractional area change there to help you out a little bit. Nice. All right. Let me remind myself of this. Oh, this is a good one. Who'd like to take this one? You're doing for time. Good. You guys can go again. Hey, you can go again if you want to. There's quite a few of you online now, though. Any other volunteers for this one? If you just joined, I was saying, if you don't want this to go online, just send me an email and we can chop it out. That's fine. So it's all about your learning.
I can have a go. Emma?
Hello, how are you?
Yeah, I'm Patrick. We met last week.
Yeah, hi, Patrick. Cool. All right, do you want to read the stem, Patrick, and then I'll show the loops?
Okay, so this is a 62-year-old admitted under ID with pyrexia of unknown origin, some non-specific back pain and abdominal pain. CT abdo-pelvis NAD, met call for hypertension, and when ICU after 3 hours, there's a rising lactate, decreased urine output, and worsening renal function. And we're looking at a TTE for escalating NORAD and what the cause is. Okay, so we have a parasternal long axis. I think the LV function looks reasonably maintained. The RV outflow tract isn't dilated. I don't think the LA looks that dilated either. We've also got a zoom in of the mitral valve. And we can see the aorta a bit closer too. Mitral valve, I can't see anything significant there. That looks like there's, the aortic valve doesn't look normal though. Looks like there's a bit of maybe something unusual there. And in this setting, we could be thinking about infective endocarditis, but I'd like to have a closer look. Yep. Short parasternal short axis views, the basal segments. Once again, I think the LV function looks reasonably preserved. And I think the RV, I don't think the RV looks too dilated there. Maybe it's slightly dilated, but I might wait for the 4-chamber to comment on that more. And there looks like there is a some mitral regurg there on the colour. I can't sort of quantify what that is at the moment. So I think we've come back to the parasternal long axis again. And yeah, there's there's something, the aorta, there's increased sort of density on the, possibly on one of the leaflets there. So now our apical views. So there's the top left is the 5-chamber view. There is something, there is a density there on the that leaflet close to the mitral valve. Sorry. So that might actually be the non-coronary cusp because it's near the intra-apical septum, but I'm not 100% sure. And the top right, once again, I think the mitral valve looks okay. And the bottom left, there is, sorry, the color, I'm still working on my skills at interpreting color, but I think there's there's some increased sort of turbulent flow through that aortic valve. Doesn't look like there's a large regurg. Oh, and there's some regurg as well. So maybe some stenosis and regurgitation. And once again, in the zoomed in view there, I think that that cusp there, there's a density on there. So on this view here, we've got our apical 3-chamber. And there's a significant, there's a mitral regurgitation jet there. That is probably, at least moderate, I would have thought, in severity, because, yeah, it's quite easy to see. All right, so looking at our pulse wave Doppler through the AV and the outflow tract, we've got a normal sort of VTI, mean gradient. Mean gradient isn't that high, so I don't think there's any significant stenosis. Yep. And I'm not sure what to do with the pressure half-time, sorry. And where are we here? I'm not sure what we're looking at there either, sorry.
Okay, we might end it there, Patrick.
Yeah.
Look, good attempt, especially for this, the stage of your training, and well done for having a go with that. What I might do is just bring it back to the start. I thought you had some really good points to make. If you were to summarize your findings over just say you were calling someone and you'd done an echo and you put a bit of color on, you weren't really sure what you were looking at, but you saw, how would you summarize that to I don't know, if you were calling one of your colleagues who could report echoes or something, how would you report it to them?
I would say that we've got someone with a left ventricular size and function that looks grossly normal, but I'm concerned about possible abnormality with the aortic valve with some regurg, and in this setting I'm worried about vegetation on the aortic valve.
Beautiful. And that would be so good, that you've taken all of that, put it together and come up with that, because that's essentially, what it shows. There's obviously a little bit to fine tune there and add in, but that's really the crux of it, in terms of getting someone to come and help you urgently. So let's just go through a little bit more. So I agree with you that the LV is normal size. It looks like it has normal function. The aortic valve looks highly abnormal, and you almost get the suspicion, even in this view here, whilst it's not perfect, and the aortic valve is calcified with slightly restricted opening in this view, you do worry about whether that's an independently mobile echogenicity. However, it could be blooming artifact, right? So you don't want to be over calling things. So really important to then interrogate in other views. Here, I think what we've done is we've slightly over-rotated the probe. So you often get that flattening of the septum if you slightly go more anti-clockwise, which is why the septum looks flattened. But the LV function, again, looks preserved / hyperdynamic. The color is interesting here. Does anyone want to say what you can see on this? Maybe those of you that have done a little bit more color Doppler, what we can see here in the short axis. I might slow it down for you guys. Yeah.
You're seeing both the MR and the AR, and you can probably see that the anterior leaflet of the mitral valve is fluttering. It seems like its opening is impeded by the aortic regurg jet.
Yeah, really nice, Zoe. I haven't got an M mode through that, unfortunately. So just for everyone that's learning, what Zoe's pointing out here, as we can see, so timing's really important. So guys, when would you expect to see mitral regurg?
Systole.
Systole, exactly. When would you expect to see aortic regurg?
Diastole.
Diastole, yeah. And if it's acute severe AR, what else might you expect to see, as well as systolic MR?
See some diastolic MR.
Diastolic MR, very nice, right? So slowing this down, what we're seeing here, so we've got systole, we've got the MR coming through. You all see that? And then we're coming into diastole, and then we can see the AR coming through. Can you all see that at the top there? So that's really nice, Zoe, well done. There probably is a little bit of fluttering of the anterior mitral leaflet, and that's a beautiful M mode finding that we often see in acute severe AR, especially. You get fluttering of the anterior mitral leaflet. Bit difficult to call on here, but I agree it probably does look like that. This was just showing a close-up of the aortic valve, really just to give you a bit of a hint that that's what we're worried about in this particular stem. Again, it's difficult to call just on this view, right? But you get the impression there's a bit of soft, independently mobile sort of echogenicity on the upstream portion of the valve, which is where we generally tend to see vegetations, as opposed to on the downstream portion of the valve here. And they do tend to resemble, they have sort of, when they're early vegetation, sort of a soft appearance, a little bit like myocardium, and they have independent motion. I think these are all the money shots, aren't they? And I very much appreciate, Patrick, that you're just starting out with echo, and I thought you did really well. So just pausing this, I just want to point out to everyone that you can see this independently mobile echogenicity flicking into the left ventricular outflow tract. In this context, highly suspicious for vegetation. Other differentials might be thrombus, tumor, but certainly vegetation more likely to be the cause here. The left ventricle gives you a bit of a clue about how, chronic versus acute, along with some of the other markers. So this is not a big remodeled, eccentrically remodeled left ventricle that we see in chronic severe AR. It's got hyperdynamic function. It's not dilated. These are all pointing to this being acute AR, which fits with the pathology, right? Because we're not just going to say the severity of the AR, we need to explain the mechanism and whether we think it's acute or chronic, and for that we need to put all of the clinical story together with our echo findings. This is color Doppler showing severe, eccentric, chaotic regurgitation. So what the usual things that we do to grade severity, so looking at proximal flow convergence, measuring out a vena contracta, looking at continuous wave Doppler, looking at the density and the pressure half time, you can appreciate and then looking at the jet height compared to the LVOT height and things like that, you can appreciate why that might be difficult in eccentric jets like this. Because we're not really fanning through and getting a nice proximal flow convergence or PISA. Therefore, we can't measure out a vena contracta. I didn't show you, generally we do vena contracta in the parasternal long axis, but we can do it in the apical 5 and 3 chambers as well. But it's difficult to measure out a vena contracta if we can't see the proximal flow convergence. So that makes all these extra little things that we put together, sometimes difficult to apply in acute severe AR. But we have got an obvious 2D abnormality with highly chaotic, broad aortic regurg jet. And there probably is a little bit of diastolic MR coming through there, if you can see that. Just at the early diastole there coming through with your AR as it's just finishing. Where is that? Maybe a little speck there, maybe. So coming on then to the continuous wave Doppler, this is not that helpful, is it? So it doesn't look too dense, and the pressure half time is not less than 200. And this is what we often see with eccentric jets. You're not perfectly aligned to the regurgitant flow, so you're not, often you don't see a really dense trace if you're not lined up with all the blood cells shooting back into the LV, and your pressure half time, because your angle and everything's off, and also because of the impacts of LV EDP, may not always be, very steep based on those factors. And what's the cutoff that we use generally in severe AR for pressure half time? Less than 200, isn't it, for severe? But as I say, there are caveats to that. For example, if you've got someone with, diastolic dysfunction and really high LVEDP, then you're going to equalize your pressures very quickly. So you're going to have a very short pressure half time, but that patient might only have mild AR, right? But they're going to equalize quickly with a short pressure half time because their LVEDP is high. I wasn't showing this for any other reason, but to just, slightly distract you to think, is there is there stenosis? You did mention that you thought there was stenosis through there with the color, Patrick. So again, that's obviously, if you're not familiar with color Doppler, then you might think that turbulent flow is from stenosis. And this is showing a beautiful triangular continuous wave Doppler flow through the aortic valve with, velocities of 2.7, which might put someone into potentially mild AS territory. But we have got increased volume going through that aortic valve with the aortic regurg. Often we do see high VTIs with aortic regurg because you've always got a large volume of blood coming back through, your LVOT. This is showing, for those of you that are just starting, pulse wave Doppler through in the descending aorta in the suprasternal view, just distal to your left brachiocephalic. And it shows, it's not the best picture in the world, but this is sometimes, the best that you get with TTE, especially in critically unwell patients. If I've just got my pointer, which I seem to have lost. I haven't got a pointer. Anyway, above the baseline, we can see in diastole that there is blood flow coming back up the aorta. And generally as a cutoff, if that end diastolic velocity is more than 0.2, that's more in keeping with severe AR, especially if it's in the abdominal aorta, rather than the descending aorta that we can see here. So, yeah, I mean, summarizing your echo findings, what would you like to do next for this patient, Patrick?
Well, they need appropriate antibiotic coverage and a tow to have a closer look at the valves.
Yeah, and this is the kind of question that we would ask in the Viva, and so it would be obviously attention to ABC, stabilizing your patient, optimizing preload, afterload, contractility, etc. So supporting the patient while simultaneously having multidisciplinary discussions, cardiologists, cardiothoracics, thinking about risk benefit of tow, especially if this is an unintubated patient, and just thinking about whether that's going to really change your management, or do you have enough information for the time being until this patient gets to a cardiothoracic center before anesthetizing, sedating them for a tow, which might just rock the boat a little bit too much, particularly if you're in a peripheral center with no backup plan. So those are the kind of things. Very nice. This is a tricky one, or maybe I've made it a little bit easy with the stem, but do we have someone that's going soon? Maybe any volunteers for this one? And if not, I might ask Ho-Wan to do it, if that's all right. If there's anyone else doing it next, I'd be keen for you to have a go, though. I can't see you all, I'm afraid. All right, Ho-Wan, you're up.
Yeah. So 32-year-old, day 8 postpartum, and day 6 post pericardial drain for infected pericardial effusion. Okay. So it's been a week, and recurrent med calls with tachypnea and tachycardia. So already on what sounds like an appropriate antibiotics. She's cool, but she's normotensive. To drain, there's only minimal output. She's tachycardic and hypoxic, and oliguric as well. Yeah, so on deep parasternal long axis view, I can see a small pericardial effusion consistent with the stem, and also heterogeneous left-sided pleural effusion. There also seems to be quite confluent B lines posterior to that. One more thing that I note on the parasternal long axis is there is abnormal septal motion. And again, the parasternal short axis confirms that, where there appears to be a septal bounce. I'd also like to see, actually, I'll take that back. And one more thing I notice is pericardium also appears quite thickened here, but I'd like to confirm with other views. So the slightly off axis apical 4-chamber view. I think the most salient abnormality is tricuspid regurgitation, at least moderate in severity, with sort of dense continuous wave Doppler and what looks like a flow convergence zone. But the estimated pulmonary pressure is unlikely to be elevated. Yeah, again, sort of there's abnormal septal bounce here. I mean, what I'd be worried about in this setting is constrictive pericarditis. So I'd like to see like a respirometer, if that's been done, and see if it changes with respiration. Again, yeah, what looks like plethoric IVC. Gosh, all right.
Sorry, Ho-Wan, these are not looping, but
yeah, again, bilateral pleural effusion on this lung X-ray at bases. I mean, yeah, there's sort of very abnormal lung ultrasound and echo on this lady who's postpartum, who's also had an infected pericardial effusion. Sorry, I'm trying to answer the next question, which was what more information you would need. Again, I mean, abnormal septal bounds in someone who's dyspneic, recent pericardial effusion, thickened pericardium, the most likely diagnosis for me is still constrictive pericarditis. Other things I would look for is mitral valve tissue, so E prime velocities, so medial and lateral, and the mitral inflow, and the last thing is hepatic vein pulse wave Doppler as well. So there is annulus reversus with septal E prime being higher than the lateral, which again can be a sign of constrictive pericarditis. Yeah, so so that's pulse wave. I think the first one is tricuspid inflow. Again, I like to do proper measurement, but there seems to be some variation with respiration. And in fact, looking at the mitral valve inflow, there definitely is significant variation.
Does it go down on inspiration or expiration in that mitral one? Sorry, I wasn't going to speak
so
at all.
Far, all very concerning for constrictive pathology.
Yeah, but is the velocity, is the mitral inflow reducing?
Sorry, I can't hear you.
I'm sorry. Am I muted? Can you hear me now?
Oh, is it me? Are you muted?
I'm not. I don't think.
Oh, okay, no, I can hear you now. Sorry.
Sorry. Is the mitral inflow reduced on inspiration or expiration?
So it's reduced on expiration, which is yeah, that's a bit unusual. It should be reduced on inspiration.
Which I think it is, because these are, you can't see the bottom of these traces, but as they're inspiring.
Oh yes, so
yeah,
it reduces with inspiration. Yeah, so that's consistent. So that must be pulse wave Doppler through the LVOT. So again, significant variation in LVOT BTI, again, all supporting the provisional diagnosis.
Can you be more specific about what it's showing, K1?
So variation in LVOT BTI with respiration.
Yeah, but reducing in inspiration, increasing in inspiration.
Oh yeah, sorry. So it is reducing in inspiration again. Yeah. So this one, it's a hepatic vein pulse wave Doppler, which shows prominent diastolic flow reversal during expiration. Yeah. Great work.
Very, very good job. That one's not easy, and you did excellent. Well done, Hewan. Just to go back through the case for everyone's learning. I think Hewan, you got most of the things here. So obviously there's a pleural effusion, as you say, with collapsed lung in it. It looks a bit heterogeneous. There's still a persistent pericardial effusion. The thickening of the pericardium can be helpful. So you're usually, if it's more than two millimeters, it's thickened. It looks bright, but again, your TGCs and things can alter that. And, suffice to say that you can have constriction without having a bright or thickened pericardium. In fact, a third of patients, can have constriction without demonstrating that. And sometimes MRI and CT demonstrate it better than echo. So that's one thing to say about the pericardial thickening. I think the key thing to mention, which is what you did focus on, was that septal bounce. And this is characteristic of constriction, because of the differences in, essentially you've got diastolic heart failure where you can't fill your LV because of this rigid shell that your heart is encased in. And so as you breathe in and out, you're going to bulge your septum across to the left in inspiration. It's going to bulge back to the right in expiration. I've got some pictures to show you. And also even you get changes in your septum, what we call a septal shudder. So in early diastole, you get that little shudder happening because of the differences in pressure as you get rapid filling of your LV in early diastole, because of those high filling pressures that really want to just shove blood from your LA into your LV. So you get this classic septal appearance, as you can see here in constriction. So for those of you that haven't seen constriction before, put that appearance of the septum into your sort of top shelf and remember that one. Yeah, this is just showing, as you're saying, at least moderate TR. We are getting respiratory variation in our TR trays, both the velocity and the timing. And there is a paper in Jack, saying how you often see this in constriction as well, again, because of that exaggerated ventricular interdependence with that. And we are seeing...
Quick question. Sorry, I'm about to interrupt. How do you tell if this is respiratory variation versus if it's with breathing, your targeted structure is moving in and out of the scanning plane?
Yeah, totally. So these are all the caveats. So, one of the differentials for constriction, is a patient that has sort of bad COPD, and often because they've got exaggerated respiratory variations, often they can be called constriction. And there are a few things that you can look at to try and differentiate them. So it's about putting the clinical picture together. Are there risk factors for constriction? It's really hard to separate sometimes, isn't it? Constriction versus restriction. And then also, you can get false positives with, bad emphysematous disease and things like that of your lungs. The movement in and out of plane is a really good point. I guess you can't necessarily account for that, but it's really just about putting the whole picture together. Recent pericardial effusion with strep, a week down the track from having a drain in, not getting better, needing to come to the ICU, short of breath. Often constriction can be missed because it is quite non-specific. And, obviously at the end stage, they present with essentially signs of right heart failure and congestion. But you're right, Zoe, sometimes it can be tricky to know whether they're just hypovolemic, they've got ventricular independence for other reasons. So, those patients might be obviously tamponade patients, asthma patients that are hypovolemic that you've just put on a ventilator. There's lots of causes that we see, especially in the ICU, of exaggerated ventricular interdependence. This is why, there's an algorithm, I guess, for when you might suspect constriction, because it's not just about relying on respiraphasic changes, even though that is a prominent part of the pathophysiology. Does that answer your question a little bit, or do you still want clarification on that?
Yeah, no, that's perfect. Thank you.
I think here, again, just showing the RV struggling, isn't it? It's dilating, it's impaired, probably because there's lots of tethering, around the RV as well. And you can just see beautifully, I think, that exaggerated ventricular interdependence. I just want to, this is moving in and out of plane. So I think this demonstrates, Zoe, what you're on about there, as does the tricuspid inflow. So you might say that this is collapsing. And I showed this on purpose because it is actually just moving in and out of plane. There is another loop that shows it is more plethoric. So guys, I might ask Ben if he can do a session on cases of lung, lung ultrasound and maybe some general pathology that'll come up in the Viva, because they probably would quiz you a little bit more on this. You said large pleural effusions, but obviously the collapsed lung that you can see, the spine sign, they sort of expect you to point that out. Can you all see that? You've got this, this is your right lower lung. You can see the spine here with the, spine sign showing, signifying a large pleural effusion. And they might ask you about sort of air bronchograms and, dig a little bit deeper on that if it was a general Viva case. So you beautifully said that you wanted tissue Doppler at the mitral annulus and we're looking for annulus reversus. So a really nice rule of thumb, if you've got someone with heart failure symptoms, sort of right-sided heart failure, they're short of breath and they've got a septal E prime that's more than 8, that's highly unusual. And this is one of the things that can help you differentiate whether you've got a myocardial problem with a restrictive cardiomyopathy, where you're if you've got heart failure in that setting, you're always going to have a septal E prime less than 8. But generally in constriction, because it's not an intrinsic myocardial problem, and it's because you've got your heart encased in a hard shell, basically, you often get this, as well as annulus reversus, which everyone seems to kind of remember, you get annulus paradoxus as well, where your septal E prime, is a lot higher than you would expect it to be for someone, with heart failure. So generally sort of more than 8, raises alarm bells. If you see someone with heart failure, septal E primes less than 8, just go looking for other features of constriction, because they're complicated, these patients, to diagnose sometimes, and sometimes you need to do invasive pressures with left and right heart caths. So this nicely shows, I think, annulus reversus. So we've got that tethered lateral annulus giving us an E prime of around 4. And then we've got septal E primes of around 8. Sometimes they can be much higher than this, like, sort of 12, 13. I've got some other cases showing, I think, demonstrating that annulus paradoxus a little bit more. This is, I think, exactly what Zoe was saying. I think we're actually moving in and out of plane with the tricuspid valve inflow, but classically in constriction, as you breathe in spontaneously breathing patients, as you breathe in, you lower your intrathoracic pressure, you rapidly increase RV filling obviously to a point. So you get increase in tricuspid inflow E velocity, right, during inspiration, and reduction in expiration. The opposite is true for your mitral inflow, because as you breathe in, your septum bulges across, and I might just show you these pictures actually, because I think it just describes it better. So guys, this is a key, I guess, table to be sort of aware of, because a written question could be something like compare and contrast constriction versus restriction, or constriction versus tamponade, for example. Important points about constriction. The key pathophysiology in constriction is exaggerated ventricular interdependence is key. And number 2 is dissociation of your intrathoracic and intracardiac pressures. And these 2 things are really all because you've got this rigid shell. So I might just show you what I mean by that. And this is from Cardio Nerds, which is actually really nice, and there was no need for me to try and replicate it myself. So as we inspire, we're going to increase the RV preload. As we said, that septum bulges across to the left. Obviously, you've got your transmission time for the blood to, reach the left side through the pulmonary circulation, and we get reduced LV filling with a reduced, E velocity and mitral inflow during that time. As we then expire, the blood flow to the left side of the heart increases. You get increased filling, which is very rapid on the left side. So you get, in constriction, you get very rapid early filling. So you get a really high E wave velocity with a really steep decel time. All right. So you get this sort of restrictive inflow pattern. And this is one of the things that, is it restrictive cardiomyopathy or is it constriction? And one of because they both have high E wave velocities, right, and that steep decel time, one of the things that you can use to differentiate them is generally with constriction, there's respiraphasic variation, when you have restriction, there's a lack of respiraphasic variation. It's just the same high restrictive filling pattern, throughout the whole cycle. But remember, if you've got someone with constriction that's also got elevated LAP or diastolic dysfunction underlying for whatever reason, you may not always see that respiraphasic variation in constriction. So there's definitely caveats to be aware of. As that left ventricle fills more in expiration, you get a little bit of your septum, that septum's essentially fighting for real estate, and it bulges back across to the right. And then this is why we see that, or one of the reasons why we see that expiratory reversal of flow in diastole and expiration in our hepatic veins, because your RV in expiration, it can't fill because your septum's bulging back across to the right. The pressures on the right side are really high, and so you get this diastolic flow reversal in expiration in your hepatic veins. So that's the physiology to be aware of, and these are the key echo features. So as Haywan pointed out in this case beautifully, we get the respiraphasic septal shift or the septal bounce, plethoric IVC, And you may see this thickened pericardium. So they're all sort of your 2D features. There may be a couple more that I've missed off. And then with Doppler, you see reduction in your mitral inflow in inspiration and increase in expiration. And generally 25% is used as the sort of a ballpark. But as you say, there are false, you can get patients that have no respiraphasic variation. They can still have constriction. So please, be aware of that. You have this restrictive inflow pattern because essentially, because your heart is restrained because of this fixed shell, it wants to fill very quickly in early diastole. So your raised LAP just pushes all of that blood from your left atrium into your left ventricle very quickly, and then it stops very abruptly. And this is what accounts for that dip and plateau sign, or that square root sign that you see when you do left heart cath on these patients, right? So you've got that quick early diastolic filling, stops abruptly because it's in this rigid shell. It can't expand any further, so it can't fill. And then you get equalization of your pressures. And then another thing that you see because of this ventricular interdependence, what you see with right and left heart caths is that as you're the patient's inspiring and expiring, you see an increase in your RV pressures during inspiration with a discordant reduction in your LV pressure waveform. So patients that go on to have left and right heart caths to confirm this diagnosis, those are the classic signs that you would see. And, they talk about this a lot more, I guess, in the American exam. Annulus reverses for the reasons we've mentioned with that tethered lateral annulus. You tend to have that preserved or even exaggerated medial E prime. So just always remember that if you're seeing a patient with heart failure, but they've got a high medial E prime, 8 or 9 is the magic number, always think about constriction. And then there's a mnemonic. If you can't remember the physiology off the top of your head because you haven't looked at it in a few months and you're on the spot in a Viva or whatever, there's a mnemonic which is RICE. So in restrictive cardiomyopathies, you get expiratory flow reversal in inspiration in your hepatic vein. And in constriction, you get a diastolic flow reversal in expiration. So restriction, diastolic flow reversal in inspiration, the RI, and then constriction, diastolic flow reversal in expiration, the CE of the RICE. I think I mentioned a couple of the caveats as we were going through. I can't actually see my screen there, but in practice, it's really difficult to diagnose these things. It's difficult to distinguish restriction from constriction. So just always ask for help with these. As I said, a lack of respiratory variation doesn't exclude constriction because you might have a patient that has raised pressures for other reasons with superimposed constriction on top of that. And as I mentioned, the COPD patients can sometimes be tricky because they have a lot of respiraphasic variation due to the exaggerated intrathoracic pressure changes. But one thing that you can look for, and there's papers on this, is look at their SVC flow. And in COPD, because you haven't got that rigid shell, your SVC is obviously not encased in that shell, then you get augmented forward flow in inspiration in your SVC and COPD, whereas that's you don't get that augmentation in your forward flow if you've got constriction. So that's one thing you can look at if you're considering those things. And this is what I mean. And I don't feel like this is taught very well. Like I often get a lot of questions about this, like why you get the reduction in inspiration in your mitral inflow. And it's because of this. And I think this just demonstrates it beautifully. So this is what we mean by that intrathoracic intracardiac dissociation. So usually, obviously, whatever happens in your intrathoracic pressure, that's transmitted to your cardiac chambers, and it's transmitted to your your pulmonary veins, isn't it, usually? So you can see that if in a normal patient, as you inspire, you reduce your pressures in your thorax, you reduce your intracardiac pressures, you reduce your pulmonary vein wedge pressures, and so that mitral inflow gradient stays consistent because you've got changes in all three of those things. So obviously for blood flow to happen, you need to have a gradient between your wedge pressure in your pulmonary veins to your LV, intracardiac pressures. And as long as that inflow gradient's maintained, you're going to get flow throughout the whole of inspiration, expiration. Whereas in constriction, where you've got that, again, I keep saying it, but you're just encased in this rock hard shell, your intrathoracic pressures are transmitted to your pulmonary vessels, your pulmonary veins, right? Because they're not within the rigid pericardium, but they're not transmitted to your LV, right? So as you inspire, you reduce your intrathoracic pressure, you reduce the pressure in your pulmonary veins, your wedge pressure, but you don't reduce your LV diastolic pressures, right? You don't reduce your LV filling pressures in inspiration because the heart's encased. So therefore you reduce your mitral inflow gradient. And this is the physiology that explains why you get a reduction in your mitral inflow during inspiration, and then it normalizes in expiration. That's all I wanted to say about that. So good job. I think that's the end of the cases. I've gone over by 10 minutes, which is good for me, and appreciate you all tuning in. Any questions? And please email me if you don't want your case discussion to be on. Super happy to take that, or Tara will chop it out for us. That's no problem. Thanks, guys. Any questions about that?
Thank you.
Thanks, Zoe.
Thanks, Emma.
Okay. Good job, everyone. Bye. Bye.